This is a model of the cervical spine. What lies in this space right here is the cerebellum, which is the part of the brain that controls balance. And what lies here is the brainstem, which is essentially the control center of respirations and many other functions. With Arnold-Chiari malformation, the cerebellum can be compressed, or the brainstem can be compressed, or both. In Courtney's case, it was the cerebellum that was compressed, so that balance could have been an issue for her. In addition, the C1 and C2 bones were subluxated, which meant that the C1 bone, this top bone, had moved forward and was fixed forward in relation to the lower bone, the C2 bone. What that did is decrease the available space for the spinal cord, so that once again balance can be affected, as well as many other functions in her body. Courtney always came in with her mother from the very beginning, and each step along this road I tried to involve both of them in educating them on what the diagnoses were, what the options were, what would happen if we didn't do surgery, what would happen if we did do surgery, what the risks and complications are. I think involving the family and the patient in not only the treatment options, but understanding the diagnosis is really critical. It's one of my feelings that if I can understand the problem and if I can explain it to a patient in non-medical or somewhat lay terms, if they can leave that clinic room or office room understanding the problem in detail, then I've done my job. Once she was evaluated by the neurosurgical service, we actually planned a surgery together in which we would be treating the Arnold-Chiari malformation by a decompression, followed by a stabilization procedure for the C1, C2 subluxation. The first part of the procedure is the decompression by the neurosurgical service, which actually involved removing a portion of her skull right at the base of the head. And after that, actually incising the covering of the brain and the spinal cord to relieve the pressure, and then placing a patch so that the pressure would be maintained, the pressure decrease would be maintained. After that was performed, the stabilization part involved placing a metal plate onto her head, metal screws into the spine bones of the upper neck, and connecting that with a specialized rod with a hinge, and then laying bone graft over those bones so that eventually over time that the head would actually be fused to the upper part of the neck. Here was someone who was working productive, which was actually playing sports, and we needed to maintain that level of activity as best as possible. So I think that the smoothness of transition from evaluation to accurate diagnosis to multidisciplinary surgical plan and then affecting the treatment was really the advantage of the Brigham and Women's hospital system. To see someone who has a problem, whether it's complex, simple, but something that I can help either with the surgery or not with the surgery, but to see them back to function and see them back to a fruitful and productive life, that is the reason that I do my job.